For the next session, I would like to invite on stage Brigadier K.S. Rana. Sir was formerly Professor and Head of Pediatric Neurology at Army Hospital, RNR, New Delhi, and Professor and Consultant Pediatric Neurology at AFMC, Pune. At present, Sir is working as a Senior Consultant Pediatric Neurology at Venkateshwar Hospital, Dwarka, New Delhi. Co-chairpersons in this session will be Dr. Arun Kumar Agarwal, Director, Chandra Lakshmi Group of Hospitals, Ghaziabad, and Chairperson of Neurology Chapter of IAP 2018, and Dr. Sunanda Kohli, who is a practicing pediatrician in New Delhi.
Good morning, dear friends. After 3 mesmerizing lectures, we are going to have the topic which is as old as the neurology. Cerebral palsy is one of the oldest topic and the first topics when we are taught neurology. Along with epilepsy, we are going to have Dr. Michael Shevel, who is the chair of the Department of Pediatrics, McGill Faculty of Medicine, pediatrician in chief, Montreal Children's Hospital of the McGill University Health Center, Canada. Dr. Michael Shevel, please.
Okay, thank you very much. Are the slides up? Yeah, okay, great. Okay, thank you. Once again, big thanks to Shefali Gulati for the invitation and for organizing this conference. My assignment for the next 30 minutes is to discuss current strategies to prevent and manage cerebral palsy. I like to paraphrase Sir William Osler, who was actually educated at McGill University and was a full professor there for a number of years. He said back in the late 19th century, in order to know medicine, you have to know syphilis. But I like to say, in order to know pediatric neurology, you have to know cerebral palsy. I mean, if you think about it, cerebral palsy's got everything you need in child neurology. It's got objective findings, it's got findings on imaging, it's got multiple comorbidities, it challenges you in terms of diagnosis and management, and it also is a lifelong disorder, so it enables you to form a very nice therapeutic relationship with children and their families. The most recent definition is one that's about 10 years old, and that characterizes cerebral palsy as a group of permanent disorders of the development of movement and posture, causing activity limitations that are attributed to non-progressive disturbances in the developing fetal or infant brain. So I just want to pause there and say that, so all patients with cerebral palsy have a neuromotor impairment. It's a result of a brain-based dysfunction that may be congenital or acquired. But what's important to realize is that the pathology underlying cerebral palsy is non-progressive. But that doesn't mean the clinical manifestations don't change over time, because the brain that is not pathologically involved continues to mature, and the challenges that a child with cerebral palsy will face will change over the lifetime. The second aspect of the definition was something that was new at that point in time, but it recognized that more often than not, cerebral palsy is not just a neuromotor disorder. And it said that the motor disorders of cerebral palsy are often accompanied by disturbances of sensation, perception, cognition, communication, and behavior, by epilepsy, and by secondary musculoskeletal problems. And indeed, these non-motor manifestations of CP may be the major challenge facing the child and the family, and may be the major point of effort on the part of a child neurologist. It's a frequent disorder. It's the most common cause of physical disability in children in the Western world. And the frequency, I have to apologize that most of the epidemiology is from high-resource settings. And if there was anything I would plead to this audience, it's to provide more data from developing countries about the profile of CP that's different and unique to your particular health service delivery systems. Our frequency is around 2 per 1,000 live births. It's a lifelong disorder. It has certain well-identified risk factors, including prematurity, maternal or newborn infection, birth asphyxia, birth trauma, and neonatal jaundice, specifically the development of a connectorous syndrome. CP has high associated morbidity and cost. I mentioned some of those comorbidities, but the big ones that challenge the child and family: epilepsy and convulsive disorders, intellectual disability and developmental delays, secondary impairments involving hearing and vision, substantive behavioral challenges, which are often underestimated and often underappreciated. And because of the progressive nature of the neuromotor impairment, orthopedic secondary deformity, dislocated hip, scoliosis being the big one. The causal spectrum varies according to the neurologic subtype of CP and whether or not there's been presence or absence of neonatal adversity, specifically an admission to a neonatal intensive care unit. And as I mentioned before, the comorbidities are frequent and often the major individual health and family challenge. Once again, just a mention of motor milestones. Remember, CP is a neuromotor impairment, so there will be motor delay. Typically, a child rolls over between 4 to 6 months, just unsupported by 6 to 9 months, pulls to stand at 9 to 12 months, and begins to walk between the 12th and 18th month of age. Red flag that should suggest to you the possibility of CP is no rolling by 6 months, no sitting by 9 months, and no walking by 18 months. Early handedness, that is definite handedness under the age of a year, is often a clue to a congenital hemiplegic cerebral palsy variant, and many of these children don't have any neonatal adversity and don't spend time in the NICU. Focal seizures may also be a clue to cerebral palsy, and you need to focus on those children who have had neonatal adversity, and those are the children with the obvious risk factors of prematurity, birth asphyxia, congenital heart disease, the presence of sepsis or an early CNS infections such as meningitis or encephalitis, and hyperbilirubinemia, especially one severe enough to require exchange transfusion or double phototherapy. As I mentioned, CP is the most common cause of pediatric physical disability encountered in high-resource settings. Its frequency is inversely related to gestational age, with a frequency under the age of 28 weeks of 80 per 1,000 live births, but at term only slightly more than 1 per 1,000 live births. In high-resource settings such as Canada, even though preterm births make up maybe 10% of all deliveries, 45% of cerebral palsy occurs in prematurely born infants. The frequency of CP is also increased by low birth weight, small for gestational age, and having suffered intrauterine growth retardation, even independent of prematurity. A baby weighing less than 1,000 grams at birth has almost a 60 in 1,000 chance of having CP, whereas a child born at an appropriate weight of 2.5 kilograms had just barely more than 1 per 1,000 risk of later CP. Increasingly, maternal infection, whether clinical or pathologic, in terms of coronary amnionitis or fetal or newborn infection, is being recognized as a risk factor for CP and as an augmenter of CP in the setting of other pathologic conditions. So CP, as I mentioned, is a recognized sequelae of intrapartum asphyxia, birth trauma, and severe hyperbilirubinemia or connectorous. It's important to realize that in high-resource setting, there are two very distinct cohorts of children who get CP. About 2/3 of them have had some neonatal adversity and come from at-risk populations who have spent time in a NICU. But there's about 1/3 that are a community-derived sample in which there's no untoward event evident during pregnancy, labor, and delivery, no neonatal incident that raises a suspicion, and early red flags such as early handedness or motor delay may give rise to a suspicion of CP. And what the challenge is that in this community-derived sample, diagnosis is often delayed beyond the second birthday. So how would we prevent CP? Well, this is based on the identification of risk factors. All suggest possible current preventative targets. We can prevent CP by addressing the major issue of prematurity. I mentioned 45% of kids in high-resource settings have been born premature, addressing peripartum infection, hyperbilirubinemia, and intrapartum asphyxia. Prematurity is the single biggest determinant of later cerebral palsy. If you had a magic wand and you wanted to have the greatest effect on limiting or diminishing the amount of cerebral palsy in a population, what you would like to do first and foremost is prevent prematurity. Well, that's a lot easier said than done. I mean, prematurity is an enormous challenge to health service delivery systems as well as social factors. How would we prevent prematurity? By providing adequate prenatal care to mothers-to-be, by reducing multiparous pregnancies, by avoiding pregnancies at the extremes of childbearing age. The young mother who's under the age of 16, the older mom who's over the age of 40, are all both at risk of increased premature delivery. Avoiding alcohol, tobacco, and drug use during pregnancy, and avoiding a short interval between pregnancies. Intervals less than 18 months increases a mother's risk of having a prem baby. Our obstetrical colleagues can more aggressively manage preterm labor through bed rest and tocolytic agents, as well as the more aggressive management of intercurrent medical conditions such as high blood pressure or preeclampsia, gestational diabetes, urinary tract infections, maternal anemia. An incompetent cervix may lead to premature labor, so cervical sutures. And indeed, the biggest challenge when it comes to prematurity is its clustering in groups that have low socioeconomic status. And also there's increasing recognition, and indeed just last week a research team at McGill University identified a specific gene that's associated with premature delivery. These also are two things that would need to be addressed, but right now they are not able to be modified by what we know. In addition, there's reasons why the premature brain is more predisposed to having an acquired lesion that leads to cerebral palsy. You have, for example, a vascular predisposition here between the deep penetrating vessels that lead to an area of relative ischemia. In addition, the cerebral perfusion pressure in the premature baby, it has a narrow range of being constant and at a lower mean arterial blood pressure than compared to the term infant. In the preterm infant, moving out of this narrow range of a constant cerebral perfusion pressure leads to a pressure-passive circulation that is predisposed to ischemia or hemorrhage, leading to the characteristic white matter injury that's associated with CP in the premature baby, which is periventricular leukomalacia. In addition, a lot of work has been done on the susceptibility of the oligodendroglial cells to ischemia and excitotoxin damage. That's the work of Stephen Back from Oregon, and the immature oligodendrocyte, which is the most common oligodendroglial cells around 26 to 34 weeks, is particularly susceptible to ischemia and excitotoxin damage, and hence that's why those babies are particularly predisposed to periventricular leukomalacia. Looking at imaging studies, they have mild and severe PVL. Mild, you just basically get some white matter signal intensity. a little bit of squaring of the ventricles. More severe, you have this characteristic blunting as well as a substantial loss of periventricular white matter and how the sulcides dip down almost right to the surface of the ventricle. What we've been seeing less and less of in high resource setting is the cystic periventricular leukomalacia, which is particularly severe and has a particularly bad prognosis. And cystic PVL has really declined substantially over the last 2 to 3 decades of newborn care. We attribute it to more antenatal beta-methasone usage, better cardiorespiratory stability in the newborn, which enables a more stable cerebral perfusion pressure and prevent that pressure passive ischemia or hemorrhage I described before. And also, we are more able to recognize and aggressively treat episodes of neonatal sepsis in the NICU. In addition, magnesium sulfate, through various observational studies, and mag sulfate was developed to treat maternal preeclampsia. It was noted that when magnesium sulfate was used, these moms would have less often infants who would later develop cerebral palsy. It is thought that the magnesium sulfate reduces vascular instability, it reduces pro-inflammatory cytokines and decreases calcium influx into cells, it reduces free radical generation of oxygen, and has a neuroprotective effect. These are all observations of the effect of mag sulfate, but the precise mechanism by which it decreases later cerebral palsy is not presently definitively known. There has, however, been multiple prospective randomized clinical trials, and these have shown that magnesium sulfate, given in the setting of treading premature birth, reduces later cerebral palsy. Doing meta-analysis, it's been shown that the number needed to treat is, sorry about that, is about 63 in order to prevent one case of cerebral palsy in a newborn who's less than 34 weeks gestational age. Now that seems like a lot of kids to treat to prevent one case of CP, but the cost-benefit analysis is favorable. Generally, you're spending, if you have to treat 63 kids with magnesium sulfate, in North America, you're spending about $10,000 US to prevent one later case of CP, which is a benefit from the societal perspective, let alone from the individual and family perspective. So right now, it's a standard practice in North America to give magnesium sulfate for imminent delivery under 34-week gestational age. In addition, there's been more aggressive recognition and treatment of peripartum infection, pro-inflammatory cytokines that are released in the setting of, for example, of chorioamnionitis, are potential mediators and augmenters for acquired brain injury in both the preterm and the term infant. And later cerebral palsy rates are increased in the setting of documented chorioamnionitis. So the net results have been routine screening of moms for GBS status and antibiotic treatment prior to delivery if indeed they are positive, antibiotic treatment of intrapartum maternal fever or signs of clinical chorioamnionitis, and reducing prolonged rupture of membrane and premature prolonged rupture of membrane. All of these have been efforts to decrease peripartum infection and decrease later cerebral palsy. Hyperbilirubinemia, I could see in one of the posters to be presented later today, is a major cause of CP in the Indian subcontinent. This is the less of an issue in Canada and North America. Perhaps maybe 6 children annually in Canada will develop kernicterus and bilirubin encephalopathy, and it, of course, leads to later dyskinetic cerebral palsy. There are certain settings, such as prematurity, small for gestational age, hemolysis, sepsis, some disorders of bilirubin conjugation, such as Crigler-Najjar syndrome, that increases your risk of connectors, and these need to be sensitized too. We routinely monitor bilirubin, we have expectant phototherapy, and we have a relatively low threshold for exchange transfusion and plasmapheresis, which probably contributes to the low rates of CP as a result of hyperbilirubinemia. One of the biggest game changers in child neurology in the last decade and a half is the prevention of CP as a result of therapeutic hypothermia for intrapartum asphyxia. There's no doubt it works. There's been established effective neuroprotective strategy, randomized controlled trial conducted in many centers in a collaborative fashion around the world, published in good journals like the New England Journal and Lancet, showed that cooling in the setting of intrapartum asphyxia led to reduced later disabilities such as CP and death. This has led to the development of cooling criteria and regional cooling centers. We have 2 cooling centers in the province of Quebec for roughly 8 million population. And the strategy had been to accurately recognize newborn encephalitis attributable to asphyxia in birthing center, try to get complete capture of all eligible infants, and transfer infants, whether or not they're eligible for cooling, to these regional cooling centers for a quick assessment and the application of a technology if necessary. It's now a standard of practice in North America to prevent CP in high resource setting. And perhaps I like to tell my residents is an example of a paradigm shift in the practice of neurology from merely a descriptive discipline to an interventional discipline. Locally, we cool term infants that are 37 weeks. Some people will cool the late preterm infant between 34 to 36 weeks, but there's a bit higher risk of hemorrhage in that population. Birth weight greater than 2 kilograms. The studies were cooling implementation within 6 hours of age, but people are now moving to cool even if they get the child beyond 6 hours of age. We have examples of cooling children up to 24 hours after the original birth, because in Quebec, it's a large province. Sometimes the weather can prevent a timely transfer by airplane from the far north down to the regional setting. We also look for at least 2 of the following features: an APGAR score of less than 5 at 10 minutes, a cord gas or an infant gas within the first hour with a pH that's acidotic below 7 or a base excess greater than -12, the need for case room resuscitation, or a sentinel event such as an abruptio or cord prolapse or uterine rupture. We also want to see the kid have a moderate to severe neonatal encephalopathy, so a minimum of neonatal seizures either clinically or on an AEEG, and we lower the core temperature to 34 degrees for a minimum of 72 hours. That is our cooling protocol. We actually looked and we used our National Cerebral Palsy Registry to see how much of CP in Canada could be prevented if all kids who were eligible to cool were cooled. And the registry is a great platform to do these type of studies because it has a multi-regional capture of children with confirmed CP. In this study, we identified term-born infants with CP who had moderate or severe neonatal encephalopathy. We identified those who met cooling criteria, and then we applied the results of the randomized controlled trials in cooling to these numbers to give an idea of the potential preventability of CP with hypothermia in Canada. At that point in time, the registry had 1,000 kids. It now has well over 2,000. We found that 543, or 54%, were born at term. 155 of them, or roughly a quarter of term-born CP, had moderate to severe encephalopathy, and roughly 64 of these 155 kids, or 40% of those with a neonatal encephalopathy, met cooling criteria. The number needed to treat in the randomized controlled trial, when you did the meta-analysis, was 8. In other words, you needed to treat 8 kids with cooling in order to prevent one later case of moderate to severe disability due to CP or death. So for every 8 cases, you would prevent one child with later CP. So looking at this Canadian cross-wide registry study, looking at the number of 64 kids who met cooling criteria and were term-born, we could probably prevent 8 cases of CP, roughly 3% of our total. So for many people, they lauded cooling as a way of preventing significant amounts of CP, but it doesn't. Only roughly 10% of kids in high resource setting have CP as a result of asphyxia, and only 1 in 8 of them, if properly cooled and meeting cooling criteria, could you prevent with hypothermia. So there's still a lot of work to be done to prevent later CP. However, we still do it because it's justified from an individual, family, and societal perspective. We are fortunate in high resource settings to have the necessary resources available to provide regional cooling centers, but one can imagine that in low resource settings, the major challenge is access to regional cooling centers, and many deliveries take place not in hospitals, and whether or not there can be low-cost, widely distributed cooling method would be an ideal solution. Engineers have developed that, but these are not yet implemented in general practice. In terms of the core management of kids with CP, the neuromotor impairment is the core feature. All children with CP should be referred to physiotherapy and occupational therapy, and that to maximize function and prevent secondary complications. Can't get that. Let me go up here. How come that's not being, oh, there you go. There is now constraint-induced movement therapy for hemiplegia by restraining the non-paretic limb, but it's not quite clear at what age to start and for what duration. Biju alluded to some aspect of pharmacologic management, and there are medical and surgical interventions that can be considered when spasticity impacts on care or participation or imparts pain and discomfort. These include Botox, given focally when combined with intensive physiotherapy, GABA agonists such as baclofen and diazepam. There are surgical mechanisms of minimizing spasticity. The orthopods are very good at tendon releases, the neurosurgeons at selective dorsal rhizotomy, and we use the intrathecal baclofen pump in children with severe CP, GMFTS level 4 and 5, in order to lessen the burden of care and to make it more easier for parents to change diapers, to dress them, position, and transfer them. I mentioned hemiplegic cerebral palsy, often the result of a peripartum arterial ischemic stroke. There's a nice randomized controlled trial published in Neurology in 2016 out of Western Canada, in which contralesional repetitive transcranial magnetic stimulation combined with constraint-induced movement therapy led to a synergistic benefit on improvement in hand function and suggesting enhancing neuroplasticity. Dystonia, Biju mentioned, there are spasticity strategies plus anticholinergics such as artane and cogentin, and it's emerging deep brain stimulation or functional neurosurgery. But the challenge here is this is done in ultra-specialized regional centers. We don't essentially have one in Canada. We send these kids to the United States, and it involves both patient selection and where you're going to implant the electrode. I mentioned comorbidities. They're frequent in CP, more than 50% of cases. There's a wide spectrum. They're a major challenge to the child and family, and often some children are frequent flyers when it comes to comorbidities. Typically, the more severely impaired child level 4 or 5 with a child with a severe spastic quadriparetic, dyskinetic, or mixed CP subtype. And just going down the list of these comorbidities, it's quite shocking to see 75% will experience pain, 50% intellectual or learning disability, 33% epilepsy, 33% non-ambulatory, 33% hip dislocation, 25% behavioral disorders, 25% sleep disorders, 25% are nonverbal, 20% drool excessively, 15% have no functional hand use, 10% cortically blind, 10% moderate to severe scoliosis requiring operative intervention, 8% tube fed, and 4% have a significant auditory impairment. This is a major challenge to families, to individuals, and to healthcare practitioners. And so the main thing is to identify the comorbidities through screening and surveillance. Another truism about cerebral palsy, if you've seen one case of cerebral palsy, you've seen one case of cerebral palsy. It's targeting individualized, symptomatic-oriented treatment. It requires partnership with a variety of different disciplines. It also requires an accurate assessment. For intellectual and learning problems, you need a psychologist. For musculoskeletal issues, orthopods and physiotherapists. For behavioral challenges and mental health issues, psychologists and psychiatrists. Speech-language pathologists for speech and language limitations, excessive drooling, the ENT, the speech-language pathologist, the OTs are helpful. Reduced hand functions, activity of daily living, the occupational therapists are helpful. And feeding issues, we rely locally on our occupational therapists and our GI colleagues. Medical responses, not everything that shakes in a child with CP
Sir, I
is
request you to wind up,
epilepsy.
sir, the time.
I have 1 minute left.
Thank you, sir.
So you need to verify that indeed it is epileptic in origin. You need to select your anticonvulsant based on seizure type, and a standard rule is avoid polytherapy, and surgery can be an option if the seizures are indeed intractable and focal and originating in non-eloquent tissue. So given that my time is up, I'll eliminate the last 2 slides. Thank you.
I know we are running shorter time, but taking the chairperson's privilege of this session, I just want to make one comment. It is challenging not only to the pediatricians treating the cerebral palsy, but in India, it's really challenging for the obstetrician who has delivered the delivery and who has attended the delivery. In India, more than 80% of the cases against obstetricians and pediatricians are due to cerebral palsy only. So we should consider all these points into the mind. And we should also remember one point, in spite of the best hands, cerebral palsy can still occur. Thank you. Now, any questions, those can be taken later on.
Sir, I will ask you my question later on. What are your views on use of aspirin in women who are having placental dysfunctions and, eclampsia? I think I'll ask you later on, sir.
Okay, you'll ask me.
Thank you, sir.
All right.
The next speaker is Dr. Bizu Hamid. He has been already introduced, so I request him to carry on his sessions.
Thanks, Dr. Rana. So this session is on neurorehabilitation and the current concepts. So when you look at the definition of rehabilitation, there are several definitions, including the one from WHO in 1980, but the one which is quite valid in the current context is the one by Seeley and Hutchinson put forward in 2006, where the rehabilitation aims to reduce the impact of brain injury by restoring damaged function, and not just restoring or compensating for lost function within the limitations of the underlying disease in order to optimize the physical, cognitive, psychological, and social function. So that is the working definition of neurorehabilitation, which is quite important. So the current trends and the advances in neurorehabilitation has been focused on how we can put neurosciences into work in optimizing neurorehabilitation. And that's where neuroplasticity comes in. So neuroplasticity is defined as the ability of the brain to reorganize itself by forming new neural connections throughout life, allowing the neurons to compensate for injury and adjust their activity in response to new situations or changes they face in their environment. And this has been an eye-opener, the fact that the brain can repair itself, which has proved the main impetus for advances in neurorehabilitation. There are two types of plasticity, the developmental plasticity and adaptive plasticity. Developmental plasticity is where, as a result of our interactions with the environment and as a consequence of the development for the child, changes in neural connections happening. So synaptogenesis, synaptic pruning, neural migration, etc. But there is the concept of adaptive plasticity where that shows the brain's ability to compensate for lost functionality due to brain damage, as well as interaction with the environment, where rerouting, sprouting, etc. happens. Both developmental and adaptive plasticity occurs across the lifespan, unlike what has been thought before. But when it comes to adaptive plasticity, it is more efficient, obviously, and effective during infancy and early childhood. Then there is the concept of Hebbian learning put forward by Donald Hebb in 1949, and that forms the important framework for bridging the neural and the behavioral levels. The key principle meaning two neurons or a group of neurons that are disconnected may become connected if they are repeatedly activated at the same time. In other words, cells or neurons which fire together wire together, and conversely, if you don't do that, then cells which fire apart wire apart. And not all experience is good. Sometimes, some type of stimulation may exaggerate deficits in this vulnerable circuit. And sometimes competitor network may be activated, which further inhibits a network which is already been injured. And when it comes to neurorehabilitation, most of our focus up until perhaps the last decade or so has been on adaptive neurorehabilitation. Everything that we do when it comes to a brain-injured child has been aimed at measures which were focused towards assisting adaptation or compensating for the impairment which resulted from the brain injury. But the shift has now moved from the adaptive towards a restorative, essentially trying to restore the brain function, because we know that the brain can repair itself. So why don't we aim our attempts, interventions towards that? Rehabilitation is a complex process, and every individual has got different needs and goals. And like I said, the focus should not be on just adapting to the environment, and we should be identifying restorative therapies. And in fact, both these therapies should be synergistic. And the key to improve this is the understanding of the mechanisms of brain plasticity. Now, synaptic plasticity, when you look at the synaptic level, essentially what happens is increased synaptogenesis and increased synaptic strength. Now, if a impulse comes onto a dendritic spine, the postsynaptic glutamate receptor is released. The glutamate is released. There is influx of sodium ions, depolarization, and the AMPA receptor is blocked by magnesium, so the magnesium is expelled, which allows the influx of calcium, which we all know. But depending on the stimulus which comes in, depending on whether it's a high frequency activity or a low frequency activity, different enzymes seems to be stimulated. For example, if it's a high frequency activity, then the calcium influx activates phosphorylation, activates the kinases, which recruits more AMPA receptors. And when there are large number of these glutamate receptors, then there is larger postsynaptic potential. In other words, this is long-term potentiation. On the other hand, if the impulse which comes to the synapse is low frequency, then instead of the activation of kinases, phosphatases are activated, which means the phosphate groups are removed, which were previously attached by the kinases. And what happens is the AMPA receptors from the surface are internalized, which causes long-term depression or synaptic strength. So this new knowledge of depending on the high frequency and the low frequency, different things can happen, has again be a key thing in planning neuroplasticity and neurorehabilitation. Adaptive and maladaptive glial changes occur following injury. Normally you have astrocytes which are sort of in a layered format and interspersed with this microglia. But when a mild injury happens, what happens is the microglial activation and astrocytes are activated, and which is useful because the activation of these astrocytes limits the spread of the injury, dampens excitotoxicity, and promotes tissue regeneration. However, if the injury is severe, then what happens is the astrocytes invade the neighboring domains, more reactive microglia, increased secretion of extracellular molecules, and persistent glial scars, which becomes impenetrable to sprouting axons. Following any brain injury, the recovery happens, which involves restoration of the neural tissue, restoration of movement, and restoration of activity in different steps. And then there is compensation, which is acquisition of new function or behavior in order to replace the function which has been lost. And that involves recruitment of new neural circuits, training of new movement sequences, and training of activity, a new activity after injury. And almost always after brain injury, spontaneous recovery happens. And then there is restoration, which can either be compensatory and cortical reorganization happens. Following the spontaneous recovery, then happens our training-induced recovery. This is the period which we want to exploit. The recovery that occurs as a result of our training and rehabilitation. And so areas which did not make a significant contribution for the particular function pre-injury can now contribute to the function post-injury. And retraining of the residual areas resulting in reorganization of the cortex and compensating for the lost function. So constraint-induced therapy had looked at whether there's a relationship between this spontaneous recovery which occurs after brain injury and cortical plasticitation, whether this relationship can be manipulated to improve the potential. And that brings us to the concept of learned known use, which essentially means if there is an injury and if the movement becomes more effortful, then that means there is less movement. That means the representation zones in the cortex contract, and this becomes a vicious cycle. Further unsuccessful motor attempts causes pain, failure, incoordination, then there is behavior suppression. And what happens is, in order to compensate for this, the brain-injured child causes compensatory behavior patterns, and that becomes positively reinforced. And less effective behavior is strengthened, and by disuse or non-use of the affected limb or affected side. That is learned known use. How to overcome this is where the underlying principle of constraint-induced therapy. So what happens is increased motivation and increased use of the affected limb by positive reinforcement, further practice and reinforcement will cause use-dependent cortical reorganization, and thus the learned known use can be reversed. And that has been shown in the clinical setup as well. Children who received constraint-induced therapy being able to improve their ability to use the hemiplegic hand significantly, even just after 2 months of treatment. Motor learning is a set of processes associated with practice or experience leading to relatively permanent changes in the capability for movement. And when it comes to motor learning, the goal is to reorganize the brain to restore and compensate for the function that has already been compromised. And through learning, we can capitalize on this. The brain will continue to remodel its neural circuitry in order to encode the new experiences and enable behavioral change. And that was the constraint-induced movements they first promoted by Taub. So you discourage the patients from using their good limb, and you encourage the use of the dysfunctional limb. So significant improvement in motor function has been shown. And then there is constraint-induced movement therapy versus forced use, and they were both based on animal studies. And again, the principle is essentially the same, but forced use involves a restrained and unstructured practice, while the constraint-induced movement therapy involves structured practice, typically 6 hours in duration. But then there was a problem with constraint-induced therapy because bimanual skills can't obviously practice when it comes to constraint-induced movement therapy, which is where the role of bimanual therapy comes in, and again shown to be improved by manual performance. Experience-dependent plasticity has got several principles, which is the repetition. So simply engaging in a task performance is not enough to drive change and plasticity. You need repetition. Repetition of a newly learned or relearned behavior repeated several times in order to induce the lasting change. And that's very important because, as we know, that a typical infant who learns to walk takes an average between 500 to 1,500 walking steps per hour. So that's what they do, like when they try to learn walking. And so that means, like in our normal clinical setup, if you do 1 to 2 hours of physiotherapy a week, will that fulfill that requirement of repetition? And how we can enable the patients to practice outside of the therapy, and that's where outreach and outpatient rehabilitation services come in. The intensity of the training matters. The time matters, because we know that the neuroplasticity changes with time, and early stimulation and intervention is important. The salience of the task is important, particularly when it comes to constraint-induced therapy. The child should be actually motivated to use the impaired limb. So the task given to the child should be interesting. The age matters. The transference refers to use of plasticity in response to one training which enhanced the acquisition of similar behaviors, and by training in a variety of settings. Then sometimes interference happens where one part of the brain competes with another part. So we have to prevent that as well, that maladaptation. So these can be used these training methods has been shown to improve both motor as well as cognitive function. And most of the seminal work has been done by Hans Forsberg group in Sweden, where they have done quite a lot of work looking at the dopamine and neuroplasticity. And they have shown in animal studies that dopaminergic terminals and receptors in the primary motor cortex will enable motor skill learning and enhance plasticity. They have shown that if you eliminate the dopaminergic terminals in the motor area, specific skill acquisition can be blocked. And when you replace the animals, even if you give oral dopamine, you can improve the skills. Hans group has also, using neuroimaging modalities, have shown the cortical dopamine receptor binding associated with cognitive training. So essentially, when it comes to training, there are enough evidence now to suggest that things are happening in the brain with training. And like Hans's group has shown, the dopamine seems to play an important role in that. Again, with cognitive training and with working memory training, Hans's group has shown that there are changes happening in the brain, particularly with dopamine receptor binding. When it comes to brain injury, particularly following stroke, two things happen. So initially there is the cortex, in the infarcted cortex, which causes the reduced GABAergic activity. And subsequently, after a few days, then happens the glutamatergic signaling. So initially there is an increased GABA, and then there is like the glutamate. So there's the yin and yang. So we need to know when is the best timing. So initially the GABA is helpful, GABAergic activity is helpful because that limits the spread of the injury. But after a few days, the role of the excitatory signaling comes in. But it is very important to find out what is the right time to act in these things. So if the idea would be to inhibit the affected part initially, and then once the initial period is over, then to stimulate the affected part. So just like in the constraint-induced therapy, we want to stimulate the affected part where the brain injury has happened so that the non-affected part doesn't overtake the affected part. Pharmacotherapy, like we said, there is enough proof for dopamine, etc. So pharmacotherapies has also been tried. For example, this was a seminal paper which looks at the effect of the norepinephrine reuptake inhibitor dexamphetamine on sensory motor recovery. And it was quite an amazing response to just a single dose of dexamphetamine in animals, in rats, following unilateral ablation of the motor cortex. And immediate and enduring acceleration of the recovery was produced by just a single dose of dexamphetamine. So the point is, pharmacotherapy can sometimes augment the training. Fluoxetine has been shown in an adult trial looking at the recovery after acute ischemic stroke. The Fugel-Meyer scores were improved in adults who had fluoxetine was given, selective serotonin reuptake inhibitor. We had shown that by blocking the glucocorticoid receptors, you can cause decreased neuronal degeneration initially. So mifepristone, by blocking the BDNF, the neurotrophin response. For example, the BDNF goes up after fluid percussion injury, an experimental model of brain injury, and when you give mifepristone, it causes significantly less neuronal degeneration. We have also shown that in cultured hippocampal cells following injury, the AMPA receptors are internalized, suggesting that if you block the AMPA receptor trafficking, then the system can be reset and ameliorate memory dysfunction. So essentially, all these things point towards pharmacotherapy perhaps being useful alongside training. Now, the other advances which helped rehabilitation is the advances made in neuroimaging. So when it comes to anatomy, we have the DTI, we have voxel-based morphometry. When it comes to function, we have PET scans, SPECT scans, fMRIs, MEG, and we can combine the anatomy and the function using simultaneous EEG and fMRI. We have statistical parametric mapping. So all these advances have directly contributed to advances in neurorehabilitation for predicting long-term outcome, for predicting the response to treatment, for behavioral training, for plasticity enhancement, and for predicting the treatment effect. For example, here in fMRI, following the Broca's and the Wernicke's area are highlighted after reciting the phrase 1, 2, 3. And then when you change the fMRI, change the listening to meaningless speech, you see that the Broca's area is not highlighted, understandably, while the Wernicke's area is highlighted. So essentially, fMRI can be used to judge these things, how your training is working. For example, here, this subject has got 37.5% of the motor cortex injured by stroke and had 11-point scale on the Fugel-Meyer scale, while this subject had 93.4% of the M1 tract injured and had gained 1 point. So that shows, like, again, using neuroimaging to judge our outcome. MEG and EEGs can be used similarly. The Sutcliffe study from Toronto has been the first study in pediatrics, actually, where they showed cortical reorganization in hemiplegia following modified constraint-induced therapy for just 3 weeks of training. Here, fMRI had shown bilateral sensory motor activation, but then after therapy, there was a shift in the laterality index from the ipsilateral to the contralateral side, and which remained even 6 months post-therapy. Forsberg's group had also shown the white matter tract integrity improving after piano training, for example. Increased prefrontal and parietal activity after working memory training. So all these shows that the neuroimaging can be used to aid your neurorehabilitative strategies. The environment is important. Enriched environments have been shown to lead to significant improvements. And then comes neuromodulation. And neuromodulation essentially is alteration or modulation of the nerve activity by delivering electrical or pharmaceutical agents directly to the target area, which includes our deep brain stimulation, etc. And then there is transcranial magnetic stimulation. essentially we are stimulating the cortex. So just like the constraint-induced therapy, where you constraint the good limb and force the bad limb to be used, essentially in the same way, transcranial direct current stimulation and transcranial magnetic stimulation essentially is doing exactly the same thing, but it's doing directly to the brain, activating the affected part. So it's like constraint-induced therapy to the brain, and that has been again shown to improve cortical excitability. And there's enough evidence around to show that transcranial magnetic stimulation and transcranial direct current stimulation improves the cortical excitability. Deep brain stimulation, we have already looked at it. Again, there are various targets, etc. Very important for target, the choice of patient and the target. The other thing which has come into recent years is vagal nerve stimulation, and this is quite important because vagal nerve stimulation is something which has been done already for epilepsy, and the question is whether the vagal nerve stimulation would be useful in the neurorehabilitation setup, and the answer seems to be yes, because particularly in animals, at least in the last 4 or 5 years, there is enough evidence to suggest that the activation, for example, this is from a rat study where the shoulder training paired with VNS seems to recruit more motor neurons. So VNS paired with forelimb training seems to enhance the reorganization of movement. Essentially how it works, just like in VNS for epilepsy, we don't exactly know, but clearly there seems to be a role for neuromodulation. This is another study which quite recently published where again they had showed vagal nerve stimulation, again animal studies, vagal nerve stimulation paired with rehabilitative training improves forelimb function after stroke. And it's not just that improving forelimb function. This group had also shown that it actually improves the cortical the plasticity, the cortical synapses by using labeling, using a pseudo-rabies vaccine labeling. And based on the back of these VNS studies on animals, there was a trial which had come out a couple of years ago on VNS paired with upper limb rehabilitation after ischemic stroke. Again, adult study, but there seems to be very promising results where there was a significant change in the Fugel-Meyer assessment upper extremity score. Again, not just VNS paired with training. So that's the whole idea. You train and you use your pharmacotherapy and you use your neuromodulation to aid your training. It's not just training on its own. It's not just pharmacotherapy on its own. It's not that selective dosal rhizotomy on its own, for example. It's all alongside other training. The skill reaching task has been one of the main important tests that which has been done in animals, because essentially the skill reaching task is similar to the adult the skill reaching task in humans. So the skill reaching task in rats and humans can be compared, and yet another thing is using closed loop systems or brain-machine-brain interfaces where the function is restored after using a neural processes. For example, this little neural processes sits in the brain, implanted onto the scalp, and stimulates the motor area. And sometimes the response can be quite surprising. So this is the stimulation is off and the skill reaching task is poor. The animal is unable to do the task. And once the stimulator is switched on, then it's able to perform the task properly. So these are all interesting findings, but it might be several years before these are actually translated into clinical practice. But closed loop systems seems to be a very interesting prospect. Then there is brain-computer interfaces, which we probably we have all shown. Again, the brain signals are linked to computer systems to create neural interface systems where the computer senses your motor intention and performs the task for you. So these are all interesting modalities in neurorehabilitation. But there are barriers because the outcomes are quite variable. There are no biomarkers. We don't know how to assess whether what we are doing is working. And most importantly, about 30-odd neuroprotection trials have failed. So we don't really know what works or what is the best way of preventing brain injuries. All these things are barriers for neurotranslation, as Michael was alluding to. We don't know what's the best time to intervene. So in summary, the research in neuroscience and behavior have led to promising treatments in neurorehabilitation. And this influence can be manipulated to therapeutic advantage in individuals' brain injury. And the goal is always to promote the self-repair and reorganization and to move away from, or perhaps synergistically alongside adaptive technologies, also use restorative technologies. And that's where the paradigm shift has happened in the field of neurorehabilitation. So one three-step model which has been proposed is you determine the metabolic and the plastic status of the brain immediately after injury. You know what the brain is at level 0. And then you enhance the plastic status using your pharmacotherapy and your other neuromodulatory strategies. And then you enhance the connections that are formed by further training. But this is easier said than done. But with the advances in neuroimaging particularly and neuromodulation, it seems to be very promising in the field of neurorehabilitation. Thank you.
Thank you for that very illuminating talk, because the emerging paradigm of neurorehabilitation has been brought out very well when you started off with the adaptive and maladaptive neuroplasticity. And we're all now taking a lot of lessons from stroke, even for early intervention in children. And it's actually been seen that development of learned non-use and how that is helping overcome and the constraint therapy. This is something I was also interested in, but I just have a question. Has there been some experience of this kind of a thing on language development as well? Because they've been working on, like Hans Forsberg has been using it for motor learning and language.
So he did some seminal work with ADHD children and using, and he, it was one of the ICNA meetings, wasn't it, in Cape Town, where he described. So yes, he has shown that there is improvement in plasticity even with, I can't remember, it was not language learning as such, it was more working memory.
Both cognition and learning.
With cognition.
But then I don't know the follow-up of that. Has there been clinically?
I haven't seen any papers coming out from his particular language. And there is this other theory that you, if you do one thing, training, it helps other thing. Like for example, if there is this concept that if you train your child in chess or some other things, then they will go ahead and learn multiple languages, or it will make it easier for them to learn multiple languages, which is where trying to improve plasticity in one aspect, trying to gain, and that has been shown to work. So essentially, you can't really do one thing and then expect the plasticity to improve some other function, even though in theory it sounds very promising. But I haven't seen any, particularly in language things, but with working memory, yes, definitely.
Yeah. Though we haven't been able to give objective proof, I think most of us working in the field have seen that in early child care and development, it does work. The child who's learning a language is also able to do something better, music and mathematics. These have been, I think, observed, but then not really studied with electrophysiological stimulation.
Absolutely. Even with the piano training that Forsberg's groups had clearly shown that, when it comes to the professional piano players as to other children who've been taught piano later, there's a clear difference in this facility. So it is all interesting field. But the focus should be on restoring the function rather than just taking it for granted that the function has been lost and trying to get some adaptive methods just to get along.
Thank you.
Thank you.
Just one question. Can I have one question, please? One question.
videos and the beautiful demonstration of the rats doing the things. And we use dextroamphetamine like for ADHD and all. So why this hesitation? Or why haven't randomized controlled trials
I
been
think
done?
it hasn't really picked up, because
It
the
hasn't
last
picked
time we
up,
put in a grant for amphetamine in partial in consciousness, it didn't get funded. That was with Rope Forsyth. So I think it's still, there is a lot of inertia into thinking that pharmacotherapy won't work on its own. It's no magic bullet, but it will certainly aid your training and your rehabilitation alongside neuromodulation. So pharmacotherapy is also a sort of modulation, isn't it?
Absolutely. So it's a multidisciplinary, multi-pronged thing.
Absolutely.
And so, you use all these modalities. Now a lot is being done in India, but I mean, transcranial magnetic stimulation is not something that can't be done, but obviously resources have to be there. So many of these things are being
The problem
done.
is you
Many of
can't,
these
you
are
can't, yeah.
experimental.
The problem is you can't do it on its own. You
Yeah.
need some endpoints. You need your biomarkers. So you need some sort of neuroimaging modalities to judge whether you are working. So rather than willy-nilly just doing some stimulation, it might perhaps do more harm than good. Yes, absolutely. Yeah. Even in the UK, there's a lot of work done in hemiplegic children in mirror therapy. Yeah. Yeah.
I think with all these, we conclude this session. And one point to remember is that development of medicine is not governed only by economics alone. It is pure science. What Dr. Hamid has mentioned just now, this science, though economic constraints may be there, but we should keep on revising our knowledge, and such sort of work is important for the future. Thank you.
Thank you.